Yeah, we're good. Okay. So I
Great.
am so excited and delighted and grateful that Jeanette and Tim have offered to talk to us about this subject. Um, and I'll start with Jeanette because I feel partially responsible for the position Jeanette finds herself in today. Because I know the depth of Jeanette's knowledge, and I'm so delighted that she's my friend and colleague. So Jeanette is really the backbone of this trauma-informed palliative care community. She does so much heavy lifting in terms of coordinating and holding the space. And I think she's probably happier outside of the spotlight. That might be fair to say, yes. But also, I think she also has the courage to speak for principles she really feels strongly about. So yeah, just sat here with enormous gratitude to Jeanette for stepping up and speaking to what's really important. And I think that's reflected in everyone who's showing up here to listen to you both. So I'll say a little bit about Jeanette, and then I'll say a little bit about Tim, who I've literally just met a few moments ago, but I'm equally grateful for your company today, Tim. So Jeanette is a retired social worker. She trained with Stan Groff in holotropic breathwork facilitation and completed the 2-year psychedelic assisted therapy training with the Institute of Psychedelic Therapy. Jeanette was a volunteer guide on the Imperial College trial for the use of psychedelics in treatment of OCD and worked as a palliative care social worker at Arthur Rank Hospice in Cambridge. Tim Reed is a psychiatrist, psychotherapist, and author based in London. After degrees in neuroscience and medicine, he was a consultant liaison psychiatrist at the Royal London Hospital for 20 years, also heading the Crisis Intervention Service and developing psychological treatments for psychiatric emergencies. He held posts of clinical director and director of training. He's a fellow of the Royal College of Psychiatry and also a member of the Institute of Group Analysis. Tim was drawn to psychiatry by the work of C.G. Jung and has completed training in psychoanalytic psychotherapy, transpersonal psychology with Stanislav Grof. He's been a certified facilitator of holotropic breathwork since 2007. Tim is extensively involved in training and supervision of psychedelic-assisted therapy, and with Maria Papaspyrou is co-facilitating the Depth Relational Process Institute of Psychedelic Therapy 2-year training. So thank you both very much for being here, and thank you everyone for showing up to hear what they have to share with us. Thank you.
Thank you. And thank you, Tim. I'm very grateful for your input. Right, shall I start our screen share? Here we are. Share. And then slide from the beginning. Slideshow. There we are. Great. Can you all see that? Okay. Yeah.
Yep.
Okay, so thank you all for coming to our talk on psychedelics at end of life. Tim will get us started, and really I think of Tim as being the main presenter of this talk because of his extensive experience in work with psychedelic assisted therapy and his involvement in a trial in Australia, which he will tell us about. He will go through the origins and development of psychedelic assisted therapy and the essentials of what that therapy is about. I will then try and relate that back to the work that we're doing at the moment, because of course this way of working is still unlawful in this country other than in the context of trials. So how relevant really is that for us in our work now? And is psychedelic therapy trauma-informed? And is there anything we can maybe learn from it for our practice in palliative care? So between us, we'll talk for roughly 50 minutes, and then there'll be time for questions and discussion. Over to you, Tim.
Okay, well, thank you, Jeanette, for that introduction, and thank you all for joining us in the middle of your busy working days, and huge respect for the work that you do. And it's great to share this with you, Jeanette. Known you for many years, and this is the first time we've shared a space like this before. And thanks also for taking care of the slides, which I think would probably be beyond me. My slides are fairly basic, so yeah. So psychedelic therapy and end of life is a complex topic to unpack, and ask the question of how can we help those people who are in distress at the end of life? How do we approach our dying in a meaning-rich and fulfilling way? And is there a role for the skillful use of psychedelics, making use of their physiological and psychospiritual qualities? This work goes back a long way, and the modern way of working with psychedelics involves, as many of you probably know, an internal journey supported by therapists. I'll say a bit more about that later, but the psychedelic session itself is preceded by preparation sessions and followed by integrative therapy sessions. And this is so that the insights of a session are retained, so they don't just slip away like a half-remembered dream. And psychedelic drugs do a number of things. And just to summarize very sort of briefly and simply, they increase sensitivity, they amplify meaning, they take us to any unresolved places of trauma, often from very early in our life. And they also connect us to a sense of a bigger picture, often with a profound spiritual tone. And this is particularly likely to happen in higher doses. So I'm going to start off by saying a little bit about the use of psychedelics with end of life when their use was entirely legal, because LSD was legal until Richard Nixon's war on drugs in 1970. And in that first generation of research, over 20 years, LSD was considered to be a very useful medicine, although it did take some time to figure out how to work with it in a safe and effective way. So this story starts with Aldous Huxley, who was obviously an enormously influential author, wrote the perennial philosophy just after World War II, looking at the commonalities in world religions. And he was one of the early experimenters with psychedelics in the 1950s with the psychiatrist Humphrey Osmond, and wrote The Doors of Perception after that, which is a classic text. And he's probably one of a few people who's had the literary skills to be able to adequately describe what a psychedelic experience is like. And he became very interested in the relationship of the psychedelic experience of death. And he thought the primary task of the psycho-spiritual journey, which is a journey that maybe we all take in one way or another, is how to develop a relationship with death, how to deepen your relationship with your own death, move beyond your fear of death, and also move beyond the thoughts and behaviors associated with that fear. And he was very clear that LSD would be very helpful for the dying to make it, less of a physiological process and more of a spiritual process. And he himself organized to have an injection of LSD just an hour or so before his own passing in 1963. Didn't get much publicity because he died in the same day as JFK, who obviously stole the headlines. But the first use of LSD in clinical situations was really entirely physiological. And I want to tell you I wanted to tell you the story of Dr. Eric Kast, K-A-S-T, who was a pain physician in Chicago in the early 60s. And he started using LSD for its analgesic effect. And he thought that the increased sensory perception caused by LSD would take precedence over perception of pain. So, a very kind of pain-centered study. But in that first study, LSD proved superior to standard powerful analgesics in a group of 50 patients. And this was an extraordinary study, really, because LSD was just given to people in hospital beds, just handed out as an everyday drug. So there was no preparation, there was no set or setting. They weren't even told that they were being given a psychedelic substance. So very, very basic use of LSD as a medication. And they found that what was surprising was that in addition to pain relief, some people had a very noticeable perspectival shift and seemed to have found a new relationship with their condition, their cancer, and their impending death. So that was surprising. And this led to a second study of over 100 patients, 128 patients, using a fairly standard dose of LSD, 100 micrograms. And they found that generally the pain seemed to diminish or even go sometimes after two to 3 hours, and the intensity of the pain diminished for up to 2 weeks. But also there are these unexpected, if you like, side effects of increased sleep, increased well-being, and less fear of death. And as these unexpected side effects caused more interest, there was a third study in 1966 which gave similar results. But Cass started trying to measure the emotion and spiritual experiences, and found that after LSD, people were generally felt better able to communicate, felt more connected to people around them, had enhanced self-confidence, and often describe happiness, happy oceanic feelings, were better able to enjoy the nuances of everyday life, and generally had an increased zest for life. But only about a quarter of the people who had LSD wanted to repeat the experience. About a half were indifferent, and a few said they definitely didn't want to. And people generally said it was hard work. The LSD had these beneficial effects, but it was hard work. So the question was how to make it less hard work. So this led to another trial where LSD was combined with psychological support, psychotherapy. And this was found to be more helpful in terms of reducing anxiety and depression, as well as pain. And then there was a whole stack of other studies along the same paths that demonstrated safety and the same promising results. And very definitely an afterglow phenomenon after the drug experience itself, with increased well-being, reduced psychopathology, and generally beneficial changes in connectedness and relationship with the world around them. So we knew all this in the mid-60s, in 1966. We knew that LSD had potentially these beneficial effects, although people did find it was quite hard work. And in that first psychedelic era, there were over 1,000 clinical papers published on classical psychedelics, involving about.
Tim, can I just ask, do you want me to move on the slides? I don't know when you want me to move the slides on.
So let me tell you.
Okay, yeah, just tell me next slide. Yeah.
Yeah. Okay. So I think we can probably move on now. Yeah. Okay, we moved on a bit late. Sorry about that. Yeah. So basically, the lesson from the first generation of research was one of safety. So next slide, please, Jeanette. And the high point of this first generation of studies was the Spring Grove program in Baltimore, that kind of straddled the period when LSD was made illegal. And this was the last patient in this study was the last patient to be dosed with LSD for a couple of generations. And this program evolved from the program for treatment of people with alcohol addiction, and was very much geared towards the induction of spiritual experiences, because that was what was thought to be really transformative for alcoholics. So it was a high dose of LSD, much higher than the doses that were used in the pain studies. And the setting was really developed to make it as comfortable and supportive as possible. So a spiritually evocative music set, a sense of a sacred setting, and a lot of preparation. They always used two co-therapists, different genders, and it was psychotherapy rich. And 100 patients went through this program, and they were all considered to be people with poor prognosis, not only because of their physical condition, but because of the depression, the anxiety, etc. No one died in any of the sessions. One person who was very ill died 4 days after a session. Family members were very much involved in the program, and as part of the preparation, a situation was created where the patient and family members could really have an opportunity to talk to each other about their feelings for each other, their feelings about the illness. So a real attempt to, clear the relational field, which was often very distorted by, denial or misleading information about the condition, etc. And safety was thought of a lot, but the sessions were videoed. The music set had a certain trajectory, so about 4 hours in, the music took on a particular spiritual tone, which was particularly likely to induce more kind of numinous states. And then the music goes to more kind of gentle heart music, and then people start coming out of it around the 7 or 8 hour mark. There's not much talking in the sessions themselves, but after the psychedelic session, there's a check-in with the participant, but the integration is really left until after that day. And then at the end of a psychedelic day, chosen people, the nearest and dearest, were invited to come into the room, and this often led to a very rewarding interaction. And the results, for what they're worth, 30% showed dramatic improvement, 40% moderate improvement, 30% no real change. A couple of people seemed to be a little worse, but only slightly. And the improvement was most measurable in depression, anxiety, pain, and fear of death. And there was a decreased need for analgesia. And one of the researchers involved in that study, Bill Richards, a psychologist, developed a research instrument called the Peak Experience Questionnaire, and found that there was a correlation between a peak experience, a spiritual experience, and clinical outcome. So should we have a look at the next slide, please, Jeanette? Yeah, so the next study with LSD was about 40 years later. And this was done in Switzerland. Switzerland has always had an unusual approach to psychedelic therapy, and there was a brief window in the 1990s when psychedelic therapy was legal, and that there was a recognized training. And LSD psychotherapy is still available in Switzerland on a compassionate use basis. So I wanted to tell you a little bit about this study because it was a groundbreaking study. It's one of the very few studies in the current psychedelic era which used LSD, and it was the first study to combine psychedelics with end of life in the second generation of research. Small study, the number of people was 12, so the conclusions are limited, but you could say it provides a proof of concept. The participants had two doses of LSD a few weeks apart and had therapy in between the sessions. The dose of LSD was a moderate dose, so it was lower than the dose that was used in the Spring Grove study, and it was there was less emphasis on the generation of these high spiritual experiences. And essentially, they found very significant reductions in anxiety, and also found that the treatment seemed to be really safe, and there didn't seem to be much in the way of significant side effects. And as Gasser, the principal investigator, put it, with LSD-assisted psychotherapy, the anxiety went down and stayed down. But the key phrase here is LSD psychotherapy. So much more than just giving the medication. The therapy includes the selection, the preparation, the integrative psychotherapy. So just to sort of summarize what the model was: ongoing psychotherapy over 2 to 3 months, preparatory sessions and integrative sessions, 2 LSD sessions 2 to 3 weeks apart, a moderate dose of LSD to avoid dissolving ego structures so you can remember the sessions better. Each session was accompanied by a male-female therapist dyad, an internal journey where the participants focus their awareness inwards, music playlist, usually using an eye mask, lengthy discussions between the participants, and the co-therapists are discouraged while on the LSD. At the end of the LSD experience, there's a brief check-in, but again, not a lot of talking. And then the psychotherapy, the 3 non-drug psychotherapy sessions in the weeks in between the LSD sessions. And Gasser said that most of the participants could have done with another session. So most of them actually stated a preference for more than 2 LSD sessions and a longer treatment period. Can we see the next slide, please, Jeanette? So then we go on to the study at Johns Hopkins using psilocybin. And psilocybin is really very similar to LSD. It's another classical psychedelic, but the duration of action is longer. So rather than a 7-8 hour journey with LSD, the psilocybin journey is more like 4 to 6 hours. It's easier to work with. And in this study, 50 or so cancer patients, life-threatening diagnosis, symptoms of depression and anxiety, an RCT crossover, placebo-controlled with a low dose. Incidentally, we always find in these low-dose studies, but the low dose is often quite effective. The low dose internal journey accompanied by the 2 co-therapists. Often people go on astonishing journeys, even though they haven't really had a proper dose of psychedelic. But in this study, it showed that the high dose psilocybin was associated with large decreases in depression, anxiety, increased quality of life, meaning of life, well-being, optimism, relationships, and spirituality. And these changes seem to be sustained at about the 6-month mark in about 80% of people. And during the treatment period itself, about 40% of the participants had significant periods of distress, feeling unsafe in some way, but they afterwards acknowledged that these difficult times were important to the eventual outcome, and none of them regretted the dosing on the next day. And that really speaks to one of the really important features of psychedelic therapy, that at some stage, generally, it's going to take you to some quite difficult places. And you need to be able to tolerate that. You need to be okay with that. And you need to be supported by your co-therapists, so that you can go deeper into that and come out the other side of that in a way that people feel is generally useful. Next slide, please, Janet. Okay, so is there another one after that?
Yeah.
Okay, so let's do that one first. So let's move on to the next one.
Cool.
Yeah. So just saying a little bit more about the basics of psychotherapy, and we take screening very seriously, and there are some people that would really be unsuitable for a treatment of a sort of intensity. You do need to be quite robust and resilient. Previous suicidal behavior, impulsivity, and psychosis are contraindications. Often people with a difficult early environment, something like early postnatal complications, adoption, early hospitalization, early surgery, things like this, these very early infantile experiences often seem to be reenacted in the psychedelic state in some way. So it's not a red flag, but it's a yellow flag. People need to be up for the journey. They need to understand a bit about what the psychedelic journey is going to involve. They need to be interested in finding meaning, in looking for a bigger picture. They need to be able to surrender, at least to some extent, to the psychedelic experience and not fight against it. Often a useful analogy is a bit like a riptide. You don't battle against a riptide, you kind of surrender to it until you get to a safer place. And then in the preparation, the standard instructions or the standard preparation model is encouraging people to really lean into whatever comes up, go into it. So it's not about symptom suppression, which is about so much of psychiatry and medicine. It's not about suppression. It's about really going into something with compassion and curiosity. Physical support is often really helpful. So co-therapists will rehearse with their participants, the hand on arm, the gentle hand on shoulder. And the purpose of this is just to really be alongside somebody in the most supportive way to help people go deeper into something. And it's really, really effective. And often, one of the things that people find is most helpful is going to a really vulnerable space and really feeling the presence of a co-therapist alongside them in that way, meeting people with that attunement. And if people have, a high grade spiritual experience, which they often do, especially at end of life, then to allow them to talk about it without, wanting to analyze it or critique it in any way or provide an explanation, but just allow yourself to witness it. So let's go back to a previous slide, please, Jeanette, which takes us back to the Australian study, which has recently been published, Ross et al. And this was an RCT, end of life, 35 people, an open label extension. So half of people had a placebo for the first dose, but everybody had 2 dosing sessions. So people either had a placebo followed by a psilocybin dose, or they had two psilocybin sessions. It was very therapy rich. I was the therapy supervisor for that trial, and the therapy was very, very high quality, very moving to be part of it. You read the paper, it's a very kind of dry paper, and it looks at the research and sort of shows that, yes, it did show a reduction. The psilocybin did show a greater reduction in anxiety, depression, fear of death, enhanced quality of life. Showed that the improvement when it came was pretty rapid, within a day, and was generally sustained at 6 months. It also showed, interestingly, that there didn't seem to be a difference between the 1 dose and the 2 doses. But the dry reporting of the research really does no justice to the beauty of the work, the profundity of the experiences of the participants, the way in which it meant so much to them, the way in which they were held so beautifully by the therapists. And we all learned so much in that study. We learned so much about the journey through cancer, how that has such a deep resonance, and I'm sure so many of you are so familiar with. The cancer journey not being just about end of life and the threat to life, but often a very dehumanizing journey through the medical system. The journey of endless appointments, loss of control, debilitating treatment, the pain, and also the effect on your humanity with the loss of role, the loss of fitness, the loss of connection, the loss of sensuality, sexuality, impairment, enjoyment activities, so many things. And this is difficult on its own, but we also found that these issues really kind of activate previous unresolved traumas of a similar resonance with so many people. So I just want to say a little bit about that and the way in which so many people have had a more difficult journey through life are more difficult to have a more difficult journey through cancer and have a much more complex psychological process. And often, we found that people will have a particular theme or feeling, something that we often call a complex, which has been very prominent throughout their life, such as themes of abandonment or betrayal or being unsafe or not being looked after, attachment issues, anger, unsatisfactory endings, anxieties about annihilation. And these are emotional themes that have really been quite dominant throughout their lives and are then exacerbated by the journey through cancer. And some of these complexes have actually contributed towards the physical illness as well. So, again, in the Australia study, we found that a lot of people who had a very late diagnosis of cancer, this was due to their reluctance to seek help, which was often related to emotional patterns flowing from, their early life, such as lack of trust in authority figures, or phobic anxiety may be related to early trauma. So it's really not surprising that so many people with terminal illness can get stuck in these very difficult feelings. so dominated by feelings of agitation and hopelessness and fear, and how these feelings with very negative charge can really dominate the psyche, and how these complex feelings have, roots in the deep past as well as in the more recent cancer journey. But we really often found that one of the benefits of a psychedelic experience can be a fundamental shift from one of these really difficult mental states, where maybe hopelessness and alienation has become dominant, to, another mental state, a much more positive mental state, which is much more positive and feels charged with hope and joy and connection. And the psychedelic journey often seems able to effect that shift in a remarkably effective way. Um, and a term for that is transmodulation. The way in which a dominant negative theme can mutate into something which is very different. And it sort of seems that having a peak experience, one of these spiritual experiences, or a sense of a bigger picture, or one of those great aha moments when things seem to make sense, these peak experiences seem to be particularly effective at transmodulation. And the other thing that really seems to help is going to really difficult places in your psyche, really vulnerable places, um, you know, really difficult. In a recreational sense, it would be called a bad trip. In psychedelic therapy, we call them challenging psychedelic experiences. But if you have one of these challenging experiences and feel very met there by the therapist, feel held and supported, so that you come through that in a productive way, often that seems to be very helpful and mutative too. So just to give you a very sort of short vignette, a woman who had a lot of trauma in her life, some difficult ancestral experiences. Her mother had been adopted. Her mother had had difficulty mothering her. She'd had difficulty being a mother herself. She had lots of attachment issues. She'd had a lot of agoraphobia through her life. She'd been abandoned by her husband. And she was one of these people that had a delayed diagnosis of cancer due to her phobic anxiety, so was diagnosed at stage 4. And in her journey, she didn't say anything for the entirety of her 5-hour journey, but she wept continuously throughout her journey. And as she said later, they were good tears, lots of nodding and saying, "Get it, I get it." And afterwards she said at the end of the day that it all started to make sense. Things started to fall into place, and she felt so much love and gratitude, and she could see why people loved her. Strong sense of a presence of the sacred. And she also felt able to accept the enormity of her illness and the teaching it is giving her. And now she wants to play for the rest of her life. She wants to play. And she felt that the medicine was medicine. It was healing medicine. And the next day, with a more kind of detailed integration session, she's had a sense of lots of love and acceptance and a trusting the unfolding of her life's journey. And it felt as though she'd found a new relationship with herself that felt very meaningful. And as part of that journey, and with so many other people, a sense of mourning, a mourning for losses in life, a sense of gratitude for what life has given, and an enhanced sense of meaning and a bigger picture that remains mysterious. Is there another slide, Jeanette? Is there another slide to look at? Okay, is there another one? Okay, so I've got a little bit more to say, but it's not attached to a slide. So look, this treatment is not available at the moment because essentially the aftermath of the war on drugs, which is 55 years old now, and the premise of Nixon's war on drugs is there's no possible medical use for these substances, so research was shut down. So these days you can buy a car, you can buy a gun, you can race a car, you can jump out of a plane, you can go climbing in the mountains, you can buy a bottle of vodka for just over 10 quid, but you cannot legally take a psychedelic medicine in this country for your own healing. or your own psychospiritual growth or to alleviate your distress. So, you know, we've got a long way to go in this country and things move slowly in this country, but there are grounds for considerable optimism and things are happening in other countries. And so I just wanted to tell you a bit about that. And in Australia, for the last couple of years, MDMA therapy for post-traumatic stress disorder has become legal. Psilocybin treatment for treatment-resistant depression has become legal under strict control with psychiatrists as the gatekeepers. There's been a big lack of trained therapists and trainers and supervisors, you know, in Australia. So the people that do have that have got some training experience in psychedelic therapy have found themselves in great demand. In Canada, since January 2022, physicians have been able to request psilocybin for compassionate use for individual patients through Canada's Special Access Program. And about 400 people have been through this process, and about 80% of requests get approved, and then people can have psilocybin assisted therapy in any centre staffed by interested clinicians. So, you know, in Canada, it seems to be working quite well. In Germany recently, compassionate use of psilocybin for treatment-resistant depression has been legalized in specialist psychiatric treatment centers. Again, the psychiatrists, the gatekeepers, and the number and scheduling of sessions are determined by clinical needs, so it's not a trial protocol. And, you know, it would be so easy to do something like that in the NHS if only we were, you know, if the legislators moved the goalposts, it wouldn't be difficult to set that up. There's a really interesting study just getting underway in Europe at the moment called PsyPal, which is a study of 100 non-cancer end-of-life participants, and they're recruiting 100 participants in four countries. I think Portugal, Netherlands, Denmark, and Germany. And the first participant was dosed in August. And you know, one of the reasons why this is so exciting is not just because of the impact on the participants and on the research, but also it's a spawning ground for probably a few hundred therapists, you know, who will then become trained and experienced and skilled in this, you know, really quite complex and delicate work. So look, I'm going to leave it there, but I just want to say my main interest is I'm a retired psychiatrist. I don't do psychiatry anymore, but my main interest is the training of therapists in this work, and we do that at the Institute of Psychedelic Therapy, and we are at present recruiting for our next 2-year training. So if anyone was interested in that, we'd be delighted to hear from you. So thanks very much for listening, and over now to my great friend Jeanette. Looking forward to hearing you, Jeanette.
Thank you, Tim. That's great, and I can totally recommend that training. I did it, and it's a wonderful experience. Okay, so that gives us a really good feel for what we've learned so far about psychedelic therapy at end of life. But of course, as Tim said, it's not lawful yet in the UK. So, is there anything we can take away from it for our work now? How relevant is it for us? Is psychedelic therapy trauma-informed? And can it teach us anything about what is needed for trauma-informed working? So, for me, part of the relevance of psychedelic therapy is that we can learn things from it for the development of trauma-informed working at end of life in general. And I think it gives us part of an answer to 2 questions which were asked at a study day of the Association of Palliative Care Social Workers in 2019. At that time, we asked, how can we support people to find meaning and purpose as they face life-threatening illness and death? And how can we create work environments and practices that will allow us to work in that way? So we heard that one dimension of what people valued about psychedelic therapy is that it puts them in touch with something transcendent or spiritual. in which spirituality, and this is a definition of the Consensus Conference on Improving the Quality of Spiritual Care as a Dimension of Palliative Care, those people decided that spirituality could be defined as that aspect of humanity that refers to the way individuals seek and express meaning and purpose, and the way that they experience their connectedness to the moment, to self, to others, to nature, and to the significant or sacred. And of course, that mirrors what Cicely Saunders said about the importance of the spiritual dimension in palliative care. And it's really at the core of my interest in psychedelic therapy at end of life. So quite some time ago, I myself had an experience using psilocybin, which completely changed my outlook on life and death. So I want to start my part of this presentation with a short account of that, to give you a bit of a flavor of the kind of experience that is possible. So I was someone who always needed to know that there was more than material reality, that I was more than my body ego, and that my life was meaningful in some way. I grew up and into young adulthood had a lot of existential anxiety. And then in 1999, I had occasion to have a high-dose psilocybin mushroom journey. And that gave me an amazing experience of being like a disembodied consciousness in a field of pure consciousness, light, love, wisdom, and compassion. I was one with that field, but also distinct, like a refraction in a crystal. If you hold a crystal up to the light, a clear crystal, and there is a schism in it, it can catch the light. And that's how it felt. And it seemed like there is nothing that is not that light, and we are all completely known and deeply loved. And that experience changed me. It took away my existential anxiety and my fear of death. I guess partly because I'd experienced myself as conscious without a body and as part of something much larger than myself. And I got a message that we are all this light, and we should see and reflect back this light in and to one another, so that we can all come to know that in ourselves. The important thing is not the content of what I saw, because everybody sees their own things. But for me, the point is the way that it changed me. And that for me is the value of engaging with these deep layers of our psyche through non-ordinary states of consciousness, and part of its relevance for palliative care. It connects us with a deeply meaningful dimension in our being that we're not normally in touch with, and that dimension speaks to us. Psychedelic therapy is one way to connect with that level, but of course there are many others: meditation, active imagination, dream work, art or music therapy. There are many, but it is a particularly powerful method. So we'll come back to that later. So we asked earlier how well aligned psychedelic therapy is with trauma-informed practice. And before I try to answer that question, because I know some people have joined us who are new to our project, I will give a quick summary of what trauma-informed practice is and its importance for palliative care. So most of you will be familiar with this definition of the Substance Abuse and Mental Health Services Administration in the US. They say that trauma results from an event, series of events, or set of circumstances that is experienced by an individual as physically or emotionally hurtful or harmful or life-threatening, and that has lasting adverse effects on the individual's functioning and on their mental, physical, social, emotional, or spiritual well-being. So childhood or developmental trauma is particularly damaging, but there are many kinds of acute and chronic individual and collective trauma to name a few: abuse in adulthood, the impact of racism and classism, environmental trauma, inter and transgenerational trauma, refugee, migration trauma, and identity trauma from oppression of marginalized identities like gender, sexuality, disability, and so on. So Barbara Hansel was one of the first people who looked at the impact of trauma on people going through palliative care. So she noted the high levels of trauma in the general population. And she said that the incidence was higher in older populations and those using palliative care services. And of course, there's a good overlap in those two. Cicely Saunders' work suggests that the trauma response contributes to something she called total pain, that interweaving of physical, psychological, emotional, social, and spiritual distress. Michael Kearney kind of broadened that out, and he said that total pain is part of what he calls soul pain, which is when we've become disconnected or alienated from the deepest and most fundamental aspects of ourselves. And it affects our body, mind, feelings, and spirit. It can look like depression, but he says it has a spiritual root. And this can impact on people's quality of life and on their chance of having a good death. I mean, Tim talked us through that as well. So trauma has very real physiological effects on us. It changes the way our brain and endocrine system work. It affects the way we experience ourselves in the world and our stress response system. So we can end up feeling on constant alert. We can be re-experiencing past trauma if memories get activated, and it can have a general impact on our thinking and mood. And naturally, because of that, we will then avoid circumstances that remind us of the early trauma, and that can include medical settings. Or when we get activated by reminders of the trauma, we can behave in antisocial ways that people don't understand, and that then get labeled as challenging behavior. So people living with trauma can find it hard to access and use palliative care services and manage the medical environments. And they can actually be re-traumatized by using healthcare because of feeling powerless, or maybe having to retell their story over and over again to the range of different people that they come across during their healthcare journey. Unresolved issues, forgotten trauma, and related symptoms can surface at the end of life, and they can reduce a person's sense of well-being and inner peace. So if that is what trauma is, what is trauma-informed, the trauma-informed approach? So it's a universal precautions approach, which means that we relate to everyone in a way that assumes that they may have had some kind of trauma. We use a trauma lens. SAMHSA identified 6 core principles as making up the essence of trauma-informed care. We create an atmosphere of safety, a safe container. We're trustworthy and transparent. We encourage peer support. There is an emphasis on collaboration and mutuality. We work in ways that are empowering to the people that we support. We give them voice and choice. And we are aware of the cultural, historical, and gender issues that may be at play for that person. Stephanie Dallum, who did a lot of research looking more generally at the impact of trauma on people who are experiencing health care, says that we need to intervene in the cyclical process of avoidant or challenging behavior by recognizing people's safety needs and adjusting how we work with them. So we need to support a change in people's coping strategy from avoidant or challenging behavior to proactive behavior. Helping the person think through, what do you find difficult in this situation? What stops you relating to us, and how can we be different with you to make it easier, and how can you manage yourself better in that situation? So taking some control, which can be very difficult. David Feldman applied these principles to palliative and end-of-life contexts, and he called his model the stepwise psychosocial model of trauma-informed working. And there are 3 stages to that model. The first stage is to do anything you can to alleviate a person's immediate distress. But once they have recovered themselves a little bit and they're calmer, you can help normalize their symptoms, explain that it's originally it was a helpful reaction to whatever the situation was that caused the trauma. But maybe now it's not so helpful anymore. You can give them psychoeducation and tools to manage the distress for themselves once it arises. And the third stage is one of trauma-specific treatment, which can be any number of different therapies or treatments. We talked about EMDR, for instance, and FLASH in previous talks. So before you come to that stage, you need a kind of intermediary preparatory stage in which you assess whether the third stage is actually right for a person, and you need to get their consent. And sometimes trauma-specific treatment, there isn't enough time for the person to go through that. That might be, from what we heard from Tim, slightly different with psychedelic therapy. But psychedelic therapy, I think, could fit in this stage 3 because it can help with the resolution of trauma. But in addition, it has that wider purpose of connecting with the depth of our psyche to find meaning and purpose. So Nadav Modeling and his colleagues in 2024 published a review of the literature to compare people's experiences of 2 sets of circumstances. So on the one hand, they looked at evidence-based psychotherapy used for post-traumatic stress disorder. And on the other hand, they looked at psychedelic therapy for a range of conditions associated with trauma. They couldn't do exactly the equivalent because there weren't enough studies of psychedelic therapy specifically for post-traumatic stress. So they picked conditions like depression or substance misuse or anxiety or post-traumatic stress disorder that had a trauma root to them. And they found a number of things in common, in particular, that the key mechanisms of change seem to be similar in both those groups, as well as was the importance of psychological safety and readiness. So psychedelic therapy has a very good safety profile, as we saw in research settings, and there is a good understanding of the effects of psychedelics. But Maudlin said, there are gaps in our knowledge. We don't actually know how psychedelic therapy increases insightfulness or occasions emotional breakthroughs or mystical type experiences. So there are no trauma-focused clinical practice guidelines in psychedelic therapy. So he feels strongly that we need to learn how to personalize care and promote safety outcomes for traumatized participants in psychedelic therapy trials. They confirmed the significance of non-pharmacological factors like interpersonal rapport, music, and environment. And so psychedelic therapy treatment is more than just symptom reduction. I mean, I say just symptom reduction, of course, that's very important, but it gives us something larger than that. Maudlin found that trauma is processed indirectly in psychedelic therapy. It wasn't the focus, but trauma material came up, so it could be integrated and became easier to live with because of a process of change in the person. People became more open to reflecting on biographical memories, past relationships, and their own part in that. And those experiences, those learnings were full of meaning and feeling, and they came out of those experiences with a greater clarity and compassion and a sense of resolution. He also described or found these transcendental or spiritual states, feelings of awe, unity, ego dissolution, or connectedness. And these were intense feelings and a visceral sense of knowing. Often these experiences, when people come out of them, they say, I have no idea how I can tell you what I experienced. It's ineffable. But nevertheless, they're left not with a belief in something. They have a sense of actually having experienced it and knowing the truth for them of what they experienced. So these are intense, immersive, and very challenging experiences. But somehow people felt strong enough to go through them. And of course, the support they receive is a big part of that. It led to people changing their perception of reality. They ended up thinking differently about themselves and about others in the world. And they were able to face these deep existential themes like birth and death. And that gave a sense of inner peace, empowerment, and purpose. There was more self-compassion and a perspective and clarity about what mattered to them, and a feeling of connectedness. And interestingly, people then looked after their health better. They valued themselves better. And they could have a sense of distance between themselves and their condition. And that was something when I was part of one of the trials at Imperial College, one of the participants described that very clearly, that he had OCD since he was about 7, and he had totally identified himself with that condition. But during the session and slightly after as well, he had a real clear sense of, I am not the OCD. I behave in ways that involve OCD, but that's not who I am, which was very helpful to him. Other things that were important, identified as important, were the relationship with the therapist, the rapport, the feeling of trust and safety. And also people mentioned the need for holistic, integrated approaches to illness. So Maudlin found a high prevalence of trauma, but he wasn't able, from his study across both groups, to find evidence of which psychotherapeutic intervention was best to use in the treatment of trauma. So he said we need a trauma-informed response across the board to minimize the risk of negative outcomes. So his conclusion was that we need to personalize care. We need to consider biopsychosocial effects of psychedelics. We need to treat the person, not the condition, in the context of their psychosocial and cultural lived experience. And like in trauma-informed practice, we ask what happened to you rather than what's wrong with you. We need to think about the attachment style, and Tim mentioned this as well. I think this is a really important point. As somebody who sometimes has attachment issues, I think we need to think about the attachment style of patients and therapists and how that can affect the therapeutic alliance and other inter and intrapersonal dynamics. We need to be aware that traumatized patients may be acutely sensitive to empathic failure, to therapist misattunement, to power imbalances, and to ruptures in the relationship. People can find it really hard to ask for support during a session because perhaps they feel really ashamed. They may have experienced betrayal in the past, moral injury. And so if they can't ask for help, they can end up feeling really isolated and withdrawn. And they may experience what happens during a psychedelic session or around it as a traumatic reenactment. So we have to be very, very careful and sensitive in how we work with people. And we need to be aware of how interpersonal trauma impacts on people's personality and on their capacity to engage in psychedelic therapy. They can enter into quite regressive states, and they can become quite demoralized if there is a, even if nobody else did that, if in their own inner world they built up the sessions as something that was really going to help them, and perhaps they have some benefit, but it isn't giving them everything that they hoped for, they can end up feeling that they failed in some way and that they blew it. And those factors can cause additional risks. So we really need to hold people very carefully as they come out of these sessions over a period of time. So psychedelic assisted therapy is aligned with the SAMHSA principles. We identified safety, so there's a good setting and skilled facilitation. There is trustworthiness and transparency, the negotiated consent and clear boundaries, clear preparation sessions. The peer support element is reflected in group psychedelic sessions, but also group integration circles that happen online or in person. Collaboration and mutuality is reflected in how patients are actively involved in setting their own therapeutic goals and in meaning making of their experiences. Empowerment and choice, again, a great emphasis on autonomy and self-directed insight. And of course, the cultural, historical, and gender issues. We are aware of the importance of spiritual traditions, cultural context, and racial elements. If the participant and the guides are from different ethnic groups, you really need to think carefully about the impact that may have. So Maudlin stressed that we need trauma-focused clinical practice guidelines, and we need clinical and organizational cultures that promote these principles. And that brings us back to the relevance of psychedelic therapy for us today. The findings and recommendations for psychedelic therapy are the same factors that are essential for trauma-informed working more widely. To support somebody to go deep by whatever method, we need to be truly present for them. And to be trauma-informed, we need listening systems. But in practice, when we want to offer the opportunity to go deep, we can hit barriers. And there's often too little time or organizational focus on this kind of need. So we end up having to prioritize practical things like assessment, treatment, managing discharge, personal care, and so on. And psychospiritual care can be sidelined sometimes and restricted to certain roles. So the need for listening systems to address soul pain, I think, is a key point where psychedelic therapy and trauma-informed palliative care connect, and where we can apply the learning from psychedelic therapy to our work practice in palliative care now. It goes back to the need for a holistic response in palliative care and a quality of being, and ultimately to a difference between two approaches to healing, two kinds of medicine. There's, on the one hand, the modern allopathic medicine, which is scientific, biomedical model. It's working through reason, observation, naturalistic theory. And then on the other hand, there's more Asclepian healing, which is perhaps more linked to psychospiritual healing through faith, ritual, and divine intervention, and through connecting with our depth. And Michael Kearney, if you're interested in looking more at how these two sit side by side with each other and how they can be integrated, Michael Kearney has written about that in this book, Mortally Wounded, but in other books as well. So, in fact, many of us have lost our sense of being more than our body ego. And by entering non-ordinary states of consciousness, we can reconnect with this knowledge, allowing us to let go of our identification with the body ego. But by learning consciously to surrender to an inner process of death and rebirth, we can alleviate our fear of death. We've kind of gone through it before. We've died before we died. And Joseph Campbell calls this inner process the hero's journey. To support this process, we need to be present for people in the same ways that trauma-informed practice offers. So we need to integrate, I think, modern medicine and Asclepian healing. We need to anchor the width, scope, and brilliance of modern medicine in the wisdom of our depth. We need to create a field of supportive attention in ourselves and in the palliative care system as a whole, so that we can be fully present for people, for them to feel deeply seen and held in their pain. And of course, the myth of the hero's journey is closely related to the myth of the wounded healer. It asks that we open to those depths and pain in ourselves, because if we are afraid of them, we will pull back from the depths in those we support. So we need to feel safe to do that work ourselves. And that all requires a change in our palliative care system, to the way it is organized, the way it thinks, feels, and breathes, the way it greets those who come to it for healing, and the way it supports its staff. So alongside ways of working with trauma, psychedelic therapy can teach us much about the skills and qualities that we need to make that change. So that's the end of my presentation. And here is the link to the Institute of Psychedelic Therapy. We've got some questions here that we can use in the discussions and reflection. We can use them or not. Just generally, what resonates with you about this, any concerns you have, do you see any potential role for that in your work? Do you think once it's legalized, it could be integrated into treatment options in your hospice? Do you agree that there is any kind of transferable learning from this that we can use now? Is it good to encourage people to connect with their inner depth? And do you feel that to support others to go deep at end of life, we are better able to do that if we've opened up to those depths in ourselves? But I will stop the share now and hand over to Bex.